All right, there we go. Now it's actually recording. All right, so for chapter 12, the first primary point that I want to get across to everybody, whether you're live here with me or watching it afterwards, the primary point that I want to get across is that you yourself watching this, yeah, watching this recording, being here synchronously, you probably don't have a psychological disorder. Even if you see like 2 or 3 or 4 symptoms that sound similar to things you've observed in yourself, that can only be diagnosed by someone who's qualified to diagnose it. I'm not a clinical psychologist. I'm a developmental psychologist. So, like I mentioned earlier before the recording started, I definitely have more knowledge of developmental disabilities, things like that, one-on-one, but I'm still not qualified to diagnose those either. So I'm not a clinical psychologist. I don't do therapy. I have worked in clinical settings in juvenile correction center, as well as with doing ABA therapy. I worked with a lot of clients who had disorders, as well as developmental delays and things like that. But I can't diagnose it. The only person who could would be someone who's qualified for that. So, with that being said, you probably don't have a psychological disorder, unless, of course, you do have one that's been diagnosed by an appropriate expert in the field. So, you might see similar symptoms to things that you feel you have. You might see similarities in your own behavior or thoughts. This doesn't mean that you have a psychological disorder that's underlying, that's caused all of your behavior. You probably will see a few symptoms talked about that you feel might fit you. This doesn't mean that you have that disorder. If it is something that's worrying you, if there's, I mean, some of these have a genetic tendency to be in family lines. If you feel that like you might, definitely go and seek counseling, seek for testing. So, but just because you see some similarities to some of these symptoms doesn't mean that you have any of these disorders. So, diagnosed by a professional is the only way you can figure it out. And please do go see a professional if you have concerns. Um, Getting therapy is, as we'll talk about, this is one of the last things in chapter 13. There is, I feel like, a little less of a stigma now than there was even 5 years ago, and definitely more than there was 15 years ago for anyone going and seeking therapy. A lot more people have gone to therapy and so realize what it's for. So it can be for treating a disorder. It can be for helping you, even if it's not an anxiety disorder. Maybe you have more anxiety than you want in your life. And so seeing a therapist can help you learn strategies and skills to reduce that anxiety, even if it's not to the level of being qualified as a disorder. If it's something that's bothering you, feel free to talk to a therapist. So definitely go see a professional, see a qualified one. Hopefully you have insurance that covers it. There are other there are doctors and clinics that can see you as well and put you on a schedule if you don't have insurance coverage too. I believe at Salt Lake Community College, I forget if it's 2 or 4 visits with a qualified counselor per semester that students have access to. So double check that, but you definitely have access to counseling services through Salt Lake Community College. $15? Okay. Okay. Oh, good, Des. I'm glad you were able to speak with your advisor about it today. And so they said it was $15 now. Yeah, I thought it used to be free. So interesting. I'll definitely need to double check that, and then I'll let everybody know for sure by next time, or maybe I'll even check that during the break today. So I can let everybody know. But there are those services available, a lot more affordable than if you had to go, say, just out of pocket somewhere. Okay, thank you, Des. So Des says, as far as Des knows, it's $15 as a copay, but it might be waived depending on situation. So definitely, either way, whether there's that $15 copay or not, it does tend to be more affordable. I know in the past there were like a certain number of visits per semester that would be free, so maybe they had to change that with COVID and being short-staffed, possibly a lot more instances of people with suffering from anxiety and depression during this time, which is totally understandable. This is a very different and strange situation for all of us. So definitely nothing to be ashamed of in any way. Get help you need, and Salt Lake Community College has access to those resources that you should and can use. All right, so with that, let's talk about the distinction. So thank you again, Des. I appreciate that. And my plan right now, unless I have to use the bathroom, take care of cat throw up, and all these kinds of things that sometimes happen during break times, I plan to check on that during break time too. So, psychiatrists versus psychologists. This is essentially just an image I pulled online that does a pretty good job explaining them, but I'll kind of break it down. You don't necessarily have to read all of this, but if you come back later and are going through the slides, this is useful. So one of the key differences is that a psychiatrist, so psychiatrist is here on the left, psychologist is here on the right. Psychiatrists are actually a medical doctor who have a degree in medicine, but specialized training in psychiatry. So mostly this involves a little bit of knowledge into counseling, but it mostly involves pharmaceuticals. So a psychiatrist would tend to be who you would go to for medicines. I believe in Utah still, I should have double checked this too. I believe in Utah still, only psychiatrists are able to prescribe medicines, as well as other medical doctors. So your family practitioner would also be able to prescribe like an antidepressant, for example. But a psychiatrist would be who you would go to for specialized psychiatric medicinal care. Psychologists are a healthcare professional, but most haven't been trained as a doctor. So the psychiatrists went to the same basic so psychiatrists here on the left side, they went to the same basic medical training as a podiatrist, a gynecologist, a family medical practitioner. So they went to the same medical school, and then their specialized residency was just in psychiatry. So psychologists might get a bachelor's degree in psychology, might not. But a psychologist will have a master's or a PhD or a PsyD in psychology of some sort. Generally, if you're going to them for therapy, they will probably have some sort of clinical psychology degree is probably what it'll be. A PsyD is essentially a doctorate of clinical psychology. It's a new kind of degree. It's very comparable with a PhD, except it's more focused on practice versus a PhD is more focused on research. So the PhD in clinical psychology has probably done research on one specific area of a specific disorder and published papers on it, versus the PsyD has probably done more in-training hours, kind of similar to a residency that a psychiatrist would. But both the PhD or the PsyD in psychology is a psychologist. So psychologists won't be prescribing medicines in some states. Some states do allow psychologists to go through the specialized, like a kind of shorter course for psychiatric medicines and then prescribe them. But I don't believe so in Utah yet. I think Arizona can. I think Colorado can. I'm not sure about Nevada, but I don't think either Utah or Idaho do still. With a psychologist, you'll generally be getting a longer span of time, 30 minutes to an hour session of sitting down with a psychologist, talking about problems. They might teach you different skills. They'll be doing specific kinds of therapies with you. We saw that video of exposure therapy with a snake. So a psychologist would be more likely to do that, the exposure therapy, versus a psychiatrist would be more likely to have something closer to like a 15-minute time window. So think about like when you go to a doctor, you might get vitals checked by a nurse, and then the doctor comes in for a couple minutes and asks you what the major problems is, gives you advice, recommendations, schedules tests, or gives you a medicine. That's essentially what the psychiatrist does too. So here on this side, they come in for a couple minutes, see how are you doing on the medicine, things need to change. up the medicine, lower the medicine dose, change the medicine entirely. That's about what the conversation is going to be. But again, some psychiatrists do have training in therapy as well, so you might get some of that there, but you're definitely going to get that from the psychologist. So, yeah. So a lot of times psychiatrists will have a office. As an example, my children's doctor is attached to the hospital. So like their office is in the building that's a hospital. So their pediatrician, that's what their doctor is called. The same thing is often true of psychiatrists. Since they did the schooling to the medical practitioner doctor stuff, and they're prescribing medicines, they tend to earn more than a psychologist. Psychologists might work within a hospital. They might even work with people in the hospital. The hospital might hire a psychologist for their nursing staff and their doctors. They might hire psychologists for emergency care of patients as well. Psychologists tend to earn a little less than, or a lot less than psychiatrists. So I don't think that's fair, but I also don't think most pay anywhere is very fair. Yeah, let's just leave that at that. So psychiatrists, major things, psychiatrists here on the left, more likely to be able to prescribe medicines, can prescribe medicines all across the US. Medical doctor, usually shorter sessions, not always therapy. It depends on the specific individual. Psychologists here on the right, they have a master's, PhD, PsyD in psychology, usually clinical psychology. Most places they can't prescribe medicine, but that's increasing in many places, getting the training to be able to prescribe medicine. A psychologist would be able to suggest to, say, a family practitioner and say, hey, could you prescribe this person an antidepressant? And if the family practitioner felt comfortable with that, they might then prescribe like if they were talking to each other. But the psychologists themselves in, say, Utah wouldn't be able to do that, prescribe it themselves, like write a prescription. Generally, a psychologist's session will be longer. They'll teach you skills. They will go through therapy techniques, things like that. So, yeah. With that, what you need just depends on what you need, essentially. So I did psychology. I'm doing a degree, a PhD in psychology, developmental psychology. So I tend to favor the psychologists over the psychiatrists. A part of that is just the familiarity with the kind of learning that they go through versus medical doctor training. I've had friends that have gone through like medical residency training and all that kind of thing. And I would much rather send like one of my children to a psychologist than a psychiatrist, but really that is literally just my opinion. So there are definitely disorders and things to be dealt with that you absolutely do need medicine. So if that is the case, then especially in Utah, a psychiatrist or having both at the same time can be really effective. And you're getting the medicine as well as the therapy. So as we talk about treatments, you'll see in many cases, not all cases, in many cases, having therapy plus medicine together is the most effective course of treatment. For some things, the medicine alone is all you need. And for other things, the therapy alone might be all you need. So we'll see that as we talk about the treatments of disorders. All right, so hopefully you have a little clearer picture of who a psychiatrist is versus a psychologist. So what we're going to do is kind of go in this order. What is abnormal behavior? How do we define what is an abnormal behavior? Then we'll talk about some neurodevelopmental disorders, anxiety and anxiety-related disorders, trauma-related, basically this whole list. We're going to go through it. We might not get through all of chapter 12. I suspect we'll get through most of chapter 12 today and then have to do some chapter 12 next time. If we do get a lot of questions, which is totally fine, we might jump back and forth also between chapter 12 and 13. So abnormal behavior is a behavior that is deviant or atypical, maladaptive or dysfunctional to daily life, and personally distressing. So what does this mean? So something that's deviant or atypical. So this could be something that's statistically unusual. So it would be, man, sometimes coming up with examples is not always easy for these. So statistically unusual, it would be statistically unusual for you to blink more than one time every 5 seconds, for example. So that would be a statistically deviant behavior, blinking more than one time every 5 seconds. With that being said, that behavior might not be maladaptive or personally distressing. So would that be considered an abnormal behavior and reach the criteria and need therapy or medical treatment? Probably not. Again, like I said at the beginning of this, I'm not diagnosing anybody here, including myself. I had those same kind of thoughts the first time I went through a psych course. It's like, oh, these kinds of things, they sound like symptoms. Would that explain all my behavior? Um, and that professor in my Psych 100 class didn't have this conversation that, hey, you probably don't have a disorder. They didn't have that till the end of the whole session of learning about disorders. So I had like a week to mull it over. So that's why I try to get that right off at the beginning. So deviant or atypical behavior could be just statistically unusual. It could be unusual compared to current cultural norms in the area that a person is. And so depending on what that is, that might not be maladaptive. It might not be problematic. That might not reach the standard by itself of an abnormal behavior that needs treatment. So it needs to, something that is deviant or atypical also needs to be maladaptive and personally distressing to be considered an abnormal behavior in need of treatment. Again, if something is personally distressing to you, even if it's not really interfering with your day-to-day life, that's fine. Like going to therapy for that would be a great idea. So going to maladaptive. So maladaptive or dysfunctional, what we're meaning by that is something that disrupts your day-to-day life, your ability to lead a satisfying life. So it's hard. I sometimes don't want to like mention examples of symptoms because I definitely don't want to like trigger things. But if you're not able to get out of bed in the morning, like 5 out of 7 days, that might be disrupting to your day-to-day life if you're not able to get to work or get to school or things like that. So if it's interfering with normal functioning, that could also be considered maladaptive. And especially if it puts yourself or other people in danger, that's obviously maladaptive as well. So you need the deviant or atypical piece, also needs to be maladaptive, so one or more of these things, and then also personally distressing. So over a long period of time or a short period of time, it really depends on the disorder. So the symptoms that you're experiencing, maybe they are personally distressing, but if it's over a really long period of time and it's not that bad, then maybe you don't feel the need, or maybe your doctor determines, oh, you don't really need to have a medicine, go to a psychologist instead of a psychiatrist. Things like that might happen. It really depends on the disorder, the kind of time that you're looking at. So similar to medical conditions, there's acute conditions that like come on really quick and give you a lot of symptoms really quick, and there's chronic conditions that can last a long time. It's also any kind of patterns of behavior if they're personally distressing. So if you have obsessive compulsive patterns of behavior and that's distressing to you, you want to get rid of them, that might be a reason to see a therapist. So if these kinds of behaviors that you're doing are making you feel guilty, shameful, or in despair, seeing a therapist about them might be appropriate. The results from the therapy might be that they help you understand that those things are not things that you need to feel guilt or shame about. Or it might be learning new patterns of behavior, learning new skills. So many people who have a personally distressing behavior, they don't realize that they might have a disorder, and so they don't necessarily seek treatment. So sometimes listening to advice from outside parties like close friends or relatives can be useful because they might point out things that might be maladaptive or might be atypical and deviant. So those are the criteria for something to reach that category of abnormal behavior, is that deviant or atypicalness, being maladaptive, and also personally distressful. So those things, and that's how we then define this behavior is abnormal behavior. All right, so we've talked about a lot of these theoretical approaches in other classes. In personality, we talked about it. In development, we talked about it. At the very beginning of the course, we talked kind of about schools of psychology. So now we're going to apply those to disorders. So the biological approach is also called the medical model. So it's essentially saying that disorders, sometimes all disorders, have or must have or may have biological origins. So in the biological approach, you might be trying to search for those origins. Psychological approach looks at your experiences, your thoughts, your emotions, your personality. So what kind of experiences have you had? What kind of thoughts about those experiences do you have? What kind of emotions about those experiences do you have that lead to current experiences and behaviors that you're having now? That's a psychological approach. A sociocultural approach essentially takes in social context. So that's an example of you might have a deviant behavior that's very different from the cultural norms here, but if you look at the sociocultural context, you might say, oh, well, that's totally normal. You move from this very different culture to this culture, and you're kind of trying to meld those things together. So this is a behavior other people might find unusual or strange, but it's really perfectly acceptable and understandable given everything that's going on, for example. That's a really vague example. Biopsychosocial model essentially takes all of those and mashes it together. So it's saying, hey, every disorder or most disorders probably have some interaction between the biological system, the psychological systems, and sociocultural factors. So with an example of that is the vulnerability stress hypothesis. And I think we've got that in the next page. So essentially that we have a biological capacity for anxiety, and if we have additional factors in our current context that might give us more anxiety, that might lead us to have the psychological experience of additional anxiety. So putting all those together. You can probably guess from what I've talked about in relation to developmental theories, kind of where I fall here. I'm definitely more on this biopsychosocial model approach to disorders. There's biological components to many disorders. There's psychological components to many disorders and sociocultural components to many of them. So if we ignore any piece of any disorder, we're kind of missing critical components to understanding it as well as treating it. So you can have, for example, medicine to help rebalance neurotransmitters in the brain to help alleviate, say, depression or anxiety. But if you're still going through the same neural network patterns of keeping thinking about that anxiety, it's not going to be as helpful as if you had the medicine plus learning the new skills of new ways to think and new ways to frame those things that are inspiring that anxiety. So putting all these together, biological, psychological, and sociocultural, it's important for both understanding and doing research about these things as well as treating these things. So the DSM-5 is the current classification system. I know there was the DSM-6 was coming soon. Has it now? At the time of the writing of your book, it hadn't come. I know I should have double checked this before. New questions come to my mind when I'm looking at going through the lecture like in real time versus when I review it before a class. All right, it looks like the DSM-6 is still, it looks like, so one thing that they've done with the DSM-5 is they've kind of updated sections, like rather than putting out a whole new diagnostic and statistics manual, they have updated sections. I guess it probably doesn't make sense that I'm saying they're updating sections until we talk about what it is. Hopefully you've read about it, but the DSM-5 was published in 2013, and essentially it's a giant book with classification systems for a bunch of psychological disorders. So the World Health Organization and also has a classification system for mental disorders. There's an international classification of diseases and related problems. So it's called the ICD-10. So there are other classification systems that a psychologist might use, or psychiatrists as well. But in the US, it's most likely that you're going to find any practitioner using the DSM-5 to diagnose. Essentially, if you'll have a section in there on depression, and it'll have a list of possible symptoms, recommended possible treatments as well, but it's mostly for classifying and describing the disorders. So it might have a section that says to be, oh my goodness, that simple word just left my brain. Diagnostic. It's right there. It's on the slides. To be diagnosed with depression, you have to meet one of these criteria, two of these criteria, and two of these criteria. For example, I think in a slide a little bit later on, I have an example of one of those pages. I should anyway. So essentially, what a therapist would do or a psychiatrist will do would be talk to a person, maybe have them do testing, and then compare their results to the various disorders. So you might need to really distinguish between, say, depression and bipolar disorder, because in a lot of ways, they present very similar symptoms. So to distinguish, is this bipolar disorder, is this depression, you've got to look at the DSM-5 and then to be able to determine, hey, we need to diagnose this person with this thing. Similar to how medical practitioners have a bunch of different tests to try and figure out, is this virus or this virus? Is this this illness or this illness? So I always think of the show House when I'm talking about the DSM-5 and classifying illnesses. Yeah. So with that, the good thing about the DSM-5 is that it does give you a common basis for communication across at least the US about disorders. So you can, let's say a patient moves. So you being the patient, you have a psychiatrist here, you move to Indiana and you get a new psychiatrist there. The psychiatrist here in Utah can send the psychiatrist in Indiana basically a little printout saying, diagnosed with this, these were the symptoms we saw, this is why we diagnosed with that, these are some of the treatment plans. So it makes it a little easier to have something that everybody can determine and decide that these symptoms equal depression. So it helps clinicians make predictions about what might happen over the course of the illness. Knowing what you're diagnosed with can provide a lot of comfort to a patient. So you might be suffering a variety of symptoms and just not know what it is. In many cases, especially with mental disorders where there's not some like physical thing that you can necessarily see outside a person, like it's not a broken bone, right? It can be hard. I think this is also getting better with the stigma for mental illnesses, but it can be hard when you don't know what it is you're suffering from. Having a name, being like, hey, this is what it is, and now I can work to fix this thing, that can be really helpful. So that's some good things about the DSM-5. Some bad things are that naming things can increase that stigma. So if you know a friend has ADHD or is suffering from depression, that some people still see that as a bad thing, right? So there might be a stigma about that. So you might not want to tell an employer about that because of comments that they've made, right? Even though it could be helpful if they knew and could help support you and change the structure of a job when you're having worse symptoms or something like that. With that, it also treats psychological disorders essentially as medical illnesses. It focuses a lot on the biological. So the DSM-5 comes more from that biological perspective rather than the biopsychosocial perspective. So that is a weakness of it as well. Also, it focuses on weaknesses and like problems people are experiencing rather than focusing on any kinds of strengths that they might have. So Yeah, it's only talking about like these are the problem symptoms to diagnose these things. It's not saying, hey, someone who is being diagnosed with Asperger's might be really good at XYZ tasks, for example. It does seem to, statistically, it does seem to increase overdiagnoses, while someone might not necessarily actually be at the level of that abnormal behavior. If they just barely fit enough of the criteria, you can diagnose them. It encourages diagnosis. That's kind of a field problem as well, and a medical and insurance problem too. So it's not just a problem with the DSM-5. And it is a little bit subjective and culturally laden, mostly from Western US culture as the emphasis. So another disadvantage that I don't think I have on here is that it's not updated very democratically, and it's not updated as frequently as maybe it should be. So we've talked about certain theorists in the past who have like really held on to their idea, even though there's a lot of evidence of other things that maybe say their theory is wrong. Same kind of thing sometimes happens with practitioners doing therapy and doing research in a specific area. While they might think something is dysfunctional or abnormal, another group might say, well, actually, there's a lot of benefits to some of these things. We need to look at it slightly differently. Maybe something would be better. Maybe ADHD is better described as something that someone is neurodivergent than as a disorder, as an example. We'll talk about that as we get there too. So there's kind of these two camps. And so in some ways, the updating of the DSM-5 kind of becomes a political battle between the two groups, who has the most money to get the most people like on board behind their ideas, who can spread their ideas wider. So in many ways, the updating of the DSM-5 is a little bit political, and which is a weakness as well. That being said, while it's not the greatest tool in the world, it's a tool we have, and it's a tool that has a lot of utility, even if it's not perfect. I mean, maybe it's a cop-out, but I'm also kind of glad that I'm a developmental psychologist and I don't have to really deal with it at the same time. I can just badmouth it from the sidelines and say, yeah, it's kind of useful, but also not. No, that's a terrible summary. It can, these advantages of it really are very real. My own personal biases of the updating being slow, I can understand some of the arguments for that, because getting good science, reliable data, valid data takes a while. So to make sure that we're updating it with something that is relevant and realistic, or deleting things that should be deleted, it makes sense to really take our time and make sure we're getting it right. So I do understand those arguments too. I am amenable to discussion on the topics. So, but it does have a lot of good points. It is one of the most widely used in the US as well. So let's talk. So I'm here talking about these disorders. I want us to hear the perspective of someone who is diagnosed, and kind of how they've experienced just that process of the stigma they've experienced, and their own perspective, versus just me saying people might feel this way. I'd like you to hear from the person's own mouth, essentially. So let's watch this. This is a person who's diagnosed with schizophrenia, and I think it does a really good job going from essentially some of the first symptoms that were noticed, to some of the initial testing that she did, to being diagnosed, having poor treatments and having good treatments, as well as stigma experienced along the way. I am going to watch it because it is kind of long. I'm going to watch it at 1.25 speed, but please do mention in the comments if that's too fast, or if the internet's stuttering or anything like that.
home for the first time to go to university, it was a bright day, brimming with hope and optimism. I'd done well at school, expectations for me were high, and I gleefully entered the student life of lectures, parties.
Maybe it's the fact that it's later in the evening, but for me, this seems too fast right now. I think my cognitive capacity is a little diminished now that it's getting darker earlier in the day. So I'm just going to slow it down right off the bat. So she's talking about her first day at university.
And traffic cone theft. Now, appearances, of course, can be deceptive, and to an extent, this feisty, energetic persona of lecture-going and traffic cone stealing was a veneer, albeit a very well-crafted and convincing one. Underneath, I was actually deeply unhappy, insecure, and fundamentally appeared to be someone with everything to hope for and aspire to. This fantasy of invulnerability was so complete that I even...
Sorry, I was trying to search in another window for the hours and information for the counseling center at Salt Lake Community College, and I accidentally fast-forwarded the video a little bit. Let's jump back to here. I think that's probably far enough.
Well, at school, expectations for me were high, and I gleefully entered the student life of lectures, parties, and traffic cone theft. Now, appearances, of course, can be deceptive, and to an extent, this feisty, energetic persona of lecture-going and traffic cone stealing was a veneer, albeit a very well-crafted and convincing one. Underneath, I was actually deeply unhappy, insecure, and fundamentally frightened. Frightened of other people, of the future, of failure, and of the emptiness that I felt was within me. But I was skilled at hiding it, and from the outside, appeared to be someone with everything to hope for and aspire to. This fantasy of invulnerability was so complete that I even deceived myself. And as the first semester ended and the second begun, there was no way that anyone could have predicted what was just about to happen. I was leaving a seminar when it started, humming to myself, fumbling with my bag, just as I'd done 100 times before, when suddenly I heard a voice calmly observe, "She is leaving the room." I looked around and there was no one there, but the clarity and decisiveness of the comment was unmistakable. Shaken, I left my books on the stairs and hurried home, and there it was again. "She is opening the door." This was the beginning. The voice had arrived. And the voice persisted. Days and then weeks of it, on, narrating everything I did in the third person. She is going to the library. She is going to a lecture. It was neutral, impassive, and even, after a while, strangely companionate and reassuring. Although I did notice that its calm exterior sometimes slipped in that it occasionally mirrored my own unexpressed emotion. So, for example, if I was angry and had to hide it, which I often did, being very adept at concealing how I really felt, then the voice would sound frustrated. Otherwise, it was neither sinister nor disturbing, although even at that point, it was clear that it had something to communicate to me about my emotions, particularly emotions which were remote and inaccessible. Now, it was then that I made a fatal mistake in that I told a friend about the voice, and she was horrified. A subtle conditioning process had begun. The implication that normal people don't hear voices, and the fact that I did, meant that something was very seriously wrong. Such fear and mistrust was infectious. Suddenly, the voice didn't seem quite so benign anymore. And when she insisted that I seek medical attention, I duly complied, and which proved to be mistake number 2. I spent some time telling the college GP about what I perceived to be the real problem: anxiety, low self-worth, fears about the future, and was met with bored indifference until I mentioned the voice, upon which he dropped his pen, swung round, and began to question me with a show of real interest. And to be fair, I was desperate for interest and help, and I began to tell him about my strange commentator. And I always wish at this point the voice had said, "She is digging her own grave." I was referred to a psychiatrist who likewise took a grim view of the voice's presence, subsequently interpreting everything I said through a lens of latent insanity. For example, I was part of a student TV station that broadcast news bulletins around the campus, and during an appointment, which was running very late, said, "I'm sorry, doctor, I've got to go. I'm reading the news at 6. Now, it's down in my medical records that Eleanor has delusions that she's a television news broadcaster." It was at this point that events began to rapidly overtake me.
So before she gets too much into that area of the discussion, I hope that gives you a good sense of the experience that she's having up to this point of starting to get diagnosed. One thing to point out is for schizophrenia, auditory hallucinations are more common than visual hallucinations. Auditory hallucinations are more common just in general in humans, whether it's induced by drugs or something like this. Auditory hallucinations are more likely. With that, you'll see also that depending on the kind of treatment, her experience with the symptoms, her interpretation of the symptoms, and her fear of these symptoms changes. So I hope you look to that. She's described kind of how she was feeling. She didn't think there was anything problematic, but then a friend was worried after she told her about the voices, and that made her think that maybe there is something wrong. And now she's kind of starting off into a downward spiral with the treatment that she's receiving. Also, I put a link to the counseling center. It looks like counseling services the fees are waived currently. What they say specifically is current counseling fees are being waived, so there is no cost for services. So that might not apply to all services. That might just be counseling services, or the website could also be out of date, especially if Des just heard today there was $15, but definitely worth contacting them. So I put the link and that paragraph that I saw on the website there. Let's jump back to the video.
Hospital admission followed, the first of many. A diagnosis of schizophrenia came next.
Sorry, I'll rewind it because this part she's kind of talking a little fast, like jumping through things. And I think I don't want anybody to get lost of the kind of timeline of what happened.
Got to go, I'm reading the news. Now it's found in my medical records that Eleanor has delusions that she's a television news broadcaster. It was at this point that events began to rapidly overtake me. A hospital admission followed, the first of many. A diagnosis of schizophrenia came next. And then, worst of all, a toxic, tormenting sense of hopelessness, humiliation, and despair about myself and my prospects. But having been encouraged to see the voice, not as an experience, but as a symptom, my fear and resistance towards it intensified. Now, essentially, this represented taking an aggressive stance towards my own mind, a kind of psychic civil war. And in turn, this caused the number of voices to increase and grow progressively hostile and menacing. Helplessly and hopelessly, I began to retreat into this nightmarish inner world in which the voices were destined to become both my persecutors and my only perceived companions. They told me, for example, that if I proved myself worthy of their help, then they could change my life back to how it had been. And a series of increasingly bizarre tasks was set, a kind of labor of Hercules. It started off quite small. For example, pull out 3 strands of hair. But gradually it grew more extreme, culminating in commands to harm myself and a particularly dramatic instruction. You see that tutor over there? You see that glass of water? We have to go over and pour it over him in front of the other students, which I actually did, and which, needless to say, did not endear me to the faculty. In effect, a vicious cycle of fear, avoidance, mistrust, and misunderstanding had been established. This was a battle in which I felt powerless and incapable of establishing any kind of peace or reconciliation. 2 years later, and the deterioration was dramatic. By now, I had the whole frenzied repertoire: terrifying voices, grotesque visions, bizarre, intractable delusions. My mental health status had been a catalyst for discrimination, verbal abuse, and physical and sexual assault. And I've been told by my psychiatrist, Eleanor, you'd be better off with cancer because cancer is easier to cure than schizophrenia. I'd been diagnosed, drugged, and discarded, and was by now so tormented by the voices that I attempted to drill a hole in my head in order to get them out.
So Celestial just made a comment, and I'm curious if you'll expand on it in the comments, that it's something you hear a lot with your clients. So by that, obviously, you can't talk specifically about like problems that clients are having, especially not identifyingly, but are you talking about in the sense of this is their experience when going through medical professionals, that they had a really hard time finding someone who helped treat them in a positive manner? Is that what you're talking about? Or can you expand on that?
Yeah. So that's how they explain their voices a lot. Most of them say it's their friend and sometimes their persecutor. And like everything she just said, my clients always say the same thing.
Great.
Um, Sorry, I don't want to go into too much into it.
No, I totally understand. Yeah, thank you for that example. Definitely shows this is a common experience for someone experiencing these kinds of problems. So I definitely appreciate that. Um, and hopefully, you see in the next little bit, she starts getting treatment from different professionals who essentially are doing a better job at treating a lot of the aspects of these problems. So see how those voices and her perception of those voices change. And hopefully, the clients that you have might be able to find professionals that can help support them in a way that they have a positive outcome, like Eleanor here did as well.
Now, looking back on the wreckage and despair of those years, it seems to me now as if someone died in that place, and yet someone else was saved. A broken and haunted person began that journey, but the person who emerged was a survivor and would ultimately grow into the person I was destined to be. Many people have harmed me in my life, and I remember them all, but the memories grow pale and faint in comparison with the people who've helped me. The fellow survivors, the fellow voice hearers, the comrades and collaborators. The mother who never gave up on me, who knew that one day I would come back to her and was willing to wait for me for as long as it took. The doctor who only worked with me for a brief time, but who reinforced his belief that recovery was not only possible, but inevitable. And during a devastating period of relapse, told my terrified family, don't give up hope. I believe that Eleanor can get through this. Sometimes, it snows as late as May, but summer always comes eventually. 14 minutes is not enough time to fully credit those good and generous people who fought with me and for me and who waited to welcome me back from that agonized, lonely place. But together, they forged a blend of courage, creativity, integrity, and an unshakable belief that my shattered self could become healed and whole. I used to say that these people saved me, but what I now know is they did something even more important in that they empowered me to save myself. And crucially, they helped me to understand something which I'd always suspected, that my voices were a meaningful response to traumatic life events, particularly childhood events, and as such were not my enemies, but a source of insight into solvable emotional problems. Now, at first, this was very difficult to believe, not least because the voices appeared so hostile and menacing. So, in this respect, a vital first step was learning to separate out a metaphorical meaning from what I'd previously interpreted to be a literal truth. So, for example, voices which threatened to attack my home, I learned to interpret as my own sense of fear and insecurity in the world rather than an actual objective danger. Now, at first, I would have believed them. I remember, for example, sitting up one night on guard outside my parents' room to protect them from what I thought was a genuine threat from the voices, because I'd had such a bad problem with self-injury that most of the cutlery in the house had been hidden. So I ended up arming myself with a plastic fork, like picnicware, and sort of sat outside the room clutching it and waiting to spring into action should anything happen. It was like, don't mess with me. Got a plastic fork, don't you know? No, strategic. But a later response, and much more useful, would be to try and deconstruct the message behind the words. So when the voices warned me not to leave the house, then I would thank them for drawing my attention to how unsafe I felt, because if I was aware of it, then I could do something positive about it. But go on to reassure both them and myself that we were safe and didn't need to feel frightened anymore.
So that's a really good example of when going through, say, cognitive behavioral therapy or a therapy that includes some of that cognitive component. What a patient might do is look at a symptom, in this case, voices, and reinterpreting it or reevaluating it in a way that you can solve a problem or understand it a little better to then solve that symptom. So as we go on talking about therapies, that when we're talking about like cognitive, we're talking about like things that you're doing in your mind, like reframing, thinking, going over memories. So essentially those cognitive things that we've talked about throughout the entire class in more of a therapeutic way, like using your cognitive capacities to do this, reinterpret and reframe this symptom in a way that then you can work on it.
I would set boundaries for the voices and try to interact with them in a way that was assertive yet respectful, establishing a slow process of communication and collaboration in which we could learn to work together and support one another. Throughout all of this, what I would ultimately realize was that each voice was closely related to aspects of myself, and that each of them carried overwhelming emotions that I'd never had an opportunity to process or resolve. Memories of sexual trauma and abuse, of anger, shame, guilt, low self-worth. The voices took the place of this pain and gave words to it. And possibly one of the greatest revelations was when I realized that the most hostile and aggressive voices actually represented the parts of me that had been hurt the most profoundly. And as such, it was these voices that needed to be shown the greatest compassion and care. It was armed with this knowledge that ultimately I would gather together my shattered self, each fragment represented by a different voice, gradually withdraw from all my medication and return to psychiatry, only this time from the other side. 10 years after the voice first came, I finally graduated, this time with the highest degree in psychology the university had ever given, and 1 year later, the highest master's, which I always say isn't bad for a mad woman. In fact, one of the voices actually dictated the answers during an exam, which technically possibly counts as cheating. And, and to be honest, sometimes I quite enjoyed their attention as well. As Oscar Wilde said, the only thing worse than being talked about is not being talked about. It also makes you very good at eavesdropping because you can listen to two conversations simultaneously, so it's not all bad. I worked in mental health services, I spoke at conferences, I published book chapters and academic articles, and I argued, and continue to do so, the relevance of the following concept, that an important question in psychiatry shouldn't be what's wrong with you, but rather what's happened to you. And all the while, I listened to my voices, with whom I'd finally learned to live with peace and respect, and which in turn reflected a growing sense of compassion, acceptance, and respect towards myself. And I remember the most moving and extraordinary moment when supporting another young woman who was terrorized by her voices and becoming fully aware for the very first time that I no longer felt that way myself, but was finally able to help someone else who was. I'm now very proud to be a part of Intervoice, the organisational body of the International Hearing Voices Movement, an initiative inspired by the work of Professor Marius Romme and Dr. Sondra Escher, which locates voice hearing as a survival strategy, a sane reaction to insane circumstances, not as an aberrant symptom of schizophrenia to be endured, but a complex, significant, and meaningful experience to be explored. Together, we envisage and enact a society that understands and respects voice hearing, supports the needs of individuals who hear voices, and which values them as full citizens. This type of society is not only possible, it's already on its way. To paraphrase Chavez, once social change begins, it cannot be reversed. You cannot humiliate the person who feels pride. You cannot oppress the people who are not afraid anymore. For me, the achievements of the Hearing Voices movement are a reminder that empathy, fellowship, justice, and respect are more than words. They are convictions and beliefs, and that beliefs can change the world. In the last 20 years, the Hearing Voices movement has established Hearing Voices networks in 26 countries across 5 continents, working together to promote dignity, solidarity, and empowerment for individuals in mental distress, to create a new language and practice of hope, which, at its very centre, lies an unshakable belief in the power of the individual. As Peter Levine has said, the human animal is a unique being, endowed with an instinctual capacity to heal and the intellectual spirit to harness this innate capacity. In this respect, for members of society, there is no greater honour or privilege than facilitating that process of healing for someone, to bear witness, to reach out a hand, to share the burden of someone's suffering, and to hold the hope for their recovery. And likewise, for survivors of distress and adversity that we remember, we don't have to live our lives forever defined by the damaging things that have happened to us. We are unique, we are irreplaceable, what lies within us can never be truly colonized, contorted, or taken away. The light never goes out. As a very wonderful doctor once said to me, don't tell me what other people have told you about yourself. Tell me about you. Thank you.
So I personally think that's really inspiring as well as eye-opening story. Going from the experience that she went through of starting to encounter those symptoms, how she thought about it, getting treatment initially, that wasn't really very, it sounds like it wasn't very good treatment essentially. So leading to anxiety, fear, of the symptoms themselves, leading to a downward spiral, not until getting treatment from other doctors, so going to a new practitioner who was able to then help, and a series of practitioners and support networks that were able to help, to now having a degree to and working to help other people suffering from those same things that are leading to these statistically unusual behaviors. So the hearing voices, that behavior that's bothering them, that's being discomforting, maladaptive, makes it hard for them to do things. And she, while she still might experience those voices, is not having all these negative things from them. She's learned techniques and skills, had medicine to help figure them out over time, and is now doing the direct action of working with networks of people across the world to help other people with those same symptoms. Inspiring and interesting to hear like that firsthand perspective, to understand what she was thinking at different points in time. So questions from that that it gave you about schizophrenia or treatment or any of that? Feel free to either raise your hand or put it in the chat as I jump back to the lecture. So there are some other videos here. I really like this one. It's pretty funny. But both of these are really good videos on the experience people have of their psychological disorders. But yeah, they do tend to be long. This one's a TED Talk. I think this one's an interview. It might be a TED Talk as well. But they're both really good. Feel free to watch them on your own time, but I don't think we're going to in class right now. So we're going to jump to neurodevelopmental disorders first. Now we'll start with autism spectrum disorders. So these range, essentially, autism spectrum disorders are an umbrella. That's why this little image is here. An umbrella where you have things that are more severe. And when I say more severe, one reason I might say that is because the book might say that. Another might be because the symptoms themselves might be more adaptive or more distressing to the individual. So with that, so there's autistic disorder and then Asperger's syndrome. And essentially the reason Asperger's syndrome is qualified as less severe is because it's slightly more neurotypical. So if neurotypical is a new word for you, that's totally okay. Neurotypical essentially means your brain is working in the typical manner. So cognitions, the neurons, the neurology, the biology of your brain is working close to the typical manner or average of most humans, versus Asperger's is in many ways close to that neurotypical manner. Autistic brain is a little further from that neurotypical manner. It works a little bit differently. So these are, and so neurotypical, hopefully you have a little better understanding of that. And then we'll bring up the term neurodivergent soon too. So these would be examples of a brain, how brains are working in a neurodivergent way. So I'll just say what it is now because it makes sense. when talking about neurotypical. So neurotypical, anything outside of that would be considered essentially neurodivergent. So yeah, I think that's pretty clear. So with that, some common symptoms for the range of autism spectrum disorders is a sensitivity to sensory information, or more sensitivity to sensory information than neurotypical people, whether that be light, sounds, specific tones, specific wavelengths, specific touches. So maybe someone's not sensitive to, say, like a pat, but maybe a pinch or like a tingling of like limbs falling asleep. Like they might be more sensitive to some kind of sensory information. Oftentimes multiple kinds of sensory information, so they're just a little bit more sensitive to to all the senses energies going into their brain. So with that, I tend to have lower levels of executive functioning and working memory. So what you might see there is that while a neurotypical brain might be able to hold 3 or 4 chunks of information at one given time, someone with this neurodivergent brain might not be able to hold that many chunks at a given time. So usually this is identified in early or middle childhood, so an autism spectrum disorder. And there is a lot of work currently being done to try and diagnose autism spectrum disorders earlier and earlier. I'm sure there's going to be a point where we get to diminishing returns, like because there are definitely precursors and symptoms that are highly correlated with a later diagnosis. But for example, one of my colleagues works in autism spectrum disorders, and they were working on diagnostic tools to diagnose 2.5-year-olds based on, I forget which specific kinds of behaviors that they were displaying, but essentially trying to diagnose even that early on to get certain treatments to help. Yeah, we'll go with that right now. So autistic disorder is a severe developmental disorders and usually has abnormalities in communication. So oftentimes there's restricted or repetitive patterns of behavior. So whether that be like doing the same kinds of actions or patterns of actions over and over again, or restricted being like not doing certain behaviors, even if it's something that would be good or useful for them. So I'm just coming up with a random example. I don't actually have any direct interaction with someone with this specific symptom, but maybe like not picking up a cup as a restricted behavior. So with that, because of this difference between neurotypical and this kind of neurodiversity or neurodivergent person, it often affects social relationships poorly. So for example, a neurotypical mother with their neurodivergent child on the autism spectrum might have a hard time knowing how to communicate with them. Maybe the mother wants to say, give hugs to try and comfort the child, but that makes the child really anxious. So finding that balance, figuring out how to communicate, that can be really hard. So with professionals, you might be able to get a better sense of like, try this, this, and this. But if you don't have access to those kinds of care services, that might be harder to figure out just on your own. It can be frustrating too. So Asperger's syndrome, relatively good language skills for someone who would be diagnosed with Asperger's syndrome, still have nonverbal language problems. So hard time picking up nonverbal cues. Also tend to have repetitive routines and preoccupations with particular subjects. One client I had a preoccupation with hive-minded insects, so things like bees, ants, things like that, that kind of like work all together in hives, termites, things like that. So they had a preoccupation with that. They would always talk about that, essentially, as an example. So what are some causes? Well, there's definitely still research being done on all these autism spectrum disorders, but there might be some abnormalities in brain structure as well as neurotransmitters. So there might be a lack of connectivity, so not as many axons and dendrite branches connecting up between certain brain areas. There might be genetic factors that increase risk for some of these autism spectrum disorders. So But with that, the causes are still not super clear. We're getting better knowledge, even since your book has been published. There's a lot better information today than there was then. And it is one that's published about pretty well. And so if you find a website about autism spectrum disorders, you'll probably be able to find some research. You can also use Google Scholar, obviously. You've been learning to use that pretty well. And your question paper twos, the midterm question papers, you did a good job on those. If any of yours did not get graded and you turned it in, send me an email and let me know if you haven't seen points on yours, because you should have by now. Sorry for the tangent. So for treatments for autism spectrum disorders, structured classroom, for a lot of, honestly, for any child's education, having a really structured classroom that's centered around their needs is a really great idea. That's hard to do. But structured classrooms are really good. Individualized teaching, so teaching to the needs, scaffolding that child, right? Small group instruction, so smaller groups. All these things are also really beneficial for any student. And then behavior modification techniques. So this is one of the primary things I did with clients on the autism spectrum was behavior modification, using things like reinforcement. Never punishment, but reinforcements to modify behaviors, to encourage behaviors and discourage certain behaviors. So yeah, I don't think I'll go into more detail than that about any of the specific behaviors. Okay, this is an example. It's kind of a generalized example. If a client has, say, a biting behavior, you might use positive reinforcement when they're not doing that, when they're handling emotions in a different way. You positively reinforce that, hopefully modify the behavior, so no longer are they doing the biting behavior. You've taught and reinforced a new behavior, as an example. Not necessarily that that's something that someone diagnosed with autism would be doing, just that's one behavior that I've used behavior modification on. Oh, I think this is just some additional information from your books. I don't know why I kept that in there. Sorry. There's a couple more facts that we didn't touch on here, but those are all in your book as well. So ADHD. So the diagnostic criteria here includes consistently showing, and so remember, these are behaviors that you might see in yourself. I see these in myself, but I've also been diagnosed with ADHD, so makes sense, right? But let's say even if you have inattention, hyperactivity, or impulsivity, if it's not too far out of the statistical norm, if it's not maladaptive to your day-to-day life, and if it's not distressing to you, then it wouldn't be qualified as an abnormal behavior. So just tying that back to one of our first topics today. So ADHD, you'd be showing inattention, hyperactivity, and impulsivity. So inattention is difficulty focusing on one thing. So jumping to more than one thing, might get bored with the task that you're doing, might only be able to stay on task a few minutes. So this is one reason why doing frequent breaks, even more frequent breaks, is good for someone with ADHD than someone with a more neurotypical brain. Hyperactivity, high levels of physical activity. So you might see more running around, more jumping, dancing, moving around, shifting in the chair. Now you might be a little more aware of times I shift in my chair. Who knows? I do feel that way when I talk about the symptoms. It's similar to when we talked about the stigma of prejudices. So in social psych, that someone who knows there's a stigma about them will feel a little bit anxious about it. Sometimes I feel that way, like talking about the symptoms. I'm like, oh, I literally just shifted in my chair before I went to this other slide. So sometimes funny. May seem like a person, especially a child, is constantly in motion. So it can be hard for, say, a teacher or a parent to diagnose that these are at an abnormal level. So, because young children have a really wide range of physical activity. There might be one child that might not be diagnosed with ADHD, but might always be moving around, right? There might be other children that are hardly moving at all. There might be children that are constantly in motion, but they wouldn't necessarily be diagnosed with ADHD because they're not showing that inattention or impulsivity. So having, say, even if a teacher is saying, hey, I think your child has ADHD, I mean, don't take that as like, oh, they've now been diagnosed. But getting tested is still a good idea because then you can know ways to support and treat and help and build on the skills that that child does have while understanding some of the things that they might struggle with. So impulsivity, difficulty curbing actions or reactions, seem not to think before acting, but that's also another thing that can be pretty common in early childhood. So with that, 9 times more boys than girls are diagnosed with ADHD. So there is disagreement over the reasons for increasing frequency of diagnosis. So over the decades, there's been higher and higher diagnoses of ADHD. So with that, one argument is that there are actually fewer kids with ADHD and they're being overdiagnosed is one of the perspectives. The other is, well, we have better diagnostic tools. We understand it better. So we're diagnosing more people more accurately. I think there's probably a little bit of both in there. My biggest concern, especially with these neurodevelopmental disorders, is that we're taking someone who's neurotypical and saying they're disordered, and it's always all the aspects of this are a problem just because the brain is working a little bit differently than other people. So with that, people with ADHD do have risks of lower academic achievement, underachievement in math and reading, substance abuse, antisocial behavior, and similar as we saw in the discussion that Eleanor was talking about, depending on how people in the socio-emotional environment, their family, their teachers, their healthcare practitioners, also with autism spectrum disorders, how they're interacting is also going to impact how negative these symptoms end up being for them. Are they in a downward spiral or are they in a positive upward spiral? So there might be genetic tendencies to develop ADHD. So brain damage in pre and postnatal is also really highly correlated. Can lead to ADHD, but I need to double check that if that is clear enough causal data or if that's actually correlational. So not sure if that's actually causal. So prefrontal cortex development delays with fewer connections and or decreased myelination is also associated with ADHD. So is that a cause of ADHD or is that what is causing ADHD at some level? So neurotransmitters dopamine and serotonin might also play a role. That's why oftentimes people with ADHD might be using antidepressants that are influencing dopamine and serotonin. So just depends what their doctor is having them try. So stimulants like Ritalin and Adderall can be helpful at improving attention. Behavior management also helps a lot in combinations with drugs. And neurofeedback is really useful. So learning skills about how the brain processes information. Mindfulness training can be really helpful. We talked about mindfulness in a lot of detail, did a mindfulness activity. Physical exercise can also help. So, yeah. Yeah, most people are diagnosed sometime in childhood or adolescence. Not very many people are diagnosed with ADHD once they're into adulthood. I would assume probably I haven't actually read a paper that's used this as the logic there. Usually the papers I've read are just like reporting those numbers, but I would assume that's probably because an adult has learned at that point skills enough that they don't end up going and getting tested. We talked about some of those. Yep. All right, so let's watch this video on neurodiversity. Let's see how long it is, because if it's too long, because we were just talking about it, so it makes sense to talk about it before. Oh no, this one is the long one. Let's definitely do a break and then we'll come back to this video. It's a really good video on neurodiversity to give you a better sense of that. So let's take a quick break though. Let's be back at 8:34 from our break. And feel free to, over the break, to post any questions or raise your hand so that I can call on you as we come back from the break. So quick break till 8:34. All right, so as everybody comes back, I'll kind of describe what this video is about. So this is another person who's been diagnosed with one of these things that we're talking about. So she's been diagnosed with an autism spectrum disorder, and so she'll talk about her experience with it, how it relates to her interactions with family, with people at school, things like that, as well as a big focus on neurodiversity and looking at it from that neurodiversity perspective, as opposed to the perspective of it just being a problem and all the aspects of being neurodivergent as negative, like only the negative, like the DSM-5, and looking at it as a disorder kind of focuses on those negatives rather than any kind of potential positives or benefits that someone whose brain works slightly different might have because of that difference of how they are thinking. So she definitely does a better job explaining it than me, probably because she prepped a whole TED Talk on it. I mean, I guess I've prepped a whole lecture about it. But I feel like she does a better job. So let's watch that and get a better sense of autism spectrum disorders, how people experience them, how it relates to their life, as well as neurodiversity. Also, wow, that's loud. Also, we're not going to watch the entire video, but we will watch a good portion of it.
My name is Elisabeth Wiklander, and I am autistic. What do you think about when you hear the word autistic? How do you react when you hear the word autism? Would you say that it is a lifelong disorder, an impairment, a disability? This is indeed the way medical language describes it, but autism is so much more than that. No diagnostic manual can truly explain the multifaceted experience of autism. It is a neurological difference with a vast spectrum of representation within its population. It can come with remarkable gifts and skills, as well as devastating traits. But autism doesn't necessarily equal disability. And thankfully, today we have a word that challenges this negative terminology: neurodiversity. Neurodiversity describes how diverse we are as human beings from a neurological perspective. It suggests that the many variations of human brains, like autistic ones, should be accepted as a natural and valuable part of humanity's genetic legacy. DNA shows us that autism is primarily a genetic condition, something that has been passed down through generations and is still widely shared in the general population. These genes can carry something so positive, in spite of the difference they cause, that they have persisted throughout our evolution and still flourish today. Some of our important inventions, pieces of art and music, and discoveries in scientific fields that have moved our world forwards come from autistic minds. With today's exciting new technologies in neuroscience, we have seen that autistic brains differ from the norm. Not only that, but it appears as if each and every one differs in its own unique way. So, autism is rich in expression, but still faces limiting generalizations. Today, I want to talk about the autism that I display, the one that blends with normality and can have catastrophic impacts on people's lives, not necessarily because of the autism itself, but because of the ignorance of it, or the failure to recognize that it is there in the first place, as I eventually would discover. Now, in social situations, we do have expectations upon one another. We use
a certain kind of rule book, which when followed, rewards us with social acceptance. But I always felt that I was different. The trouble was I couldn't explain how, and certainly not why. It felt as if I had been provided a different rule book, and that I lacked a community to fall back upon that could confirm to me that the way I interpreted the world was valid too. So I grew up feeling very misunderstood by pretty much everybody, even within my own family. If I applied what would have been my motives, my intentions upon someone else's behavior or vice versa, the outcome was often negative and very confusing. So to me, the social world became scary and unpredictable. Now, I did notice, however, especially during my school years here in Sweden, that my mind had been blessed with gifts, like analytical skills, an intense mental focus, high capacity for memorizing information, which made studying very pleasurable and easy. So in my academic pursuit, I came here to Gothenburg, where I studied at the university. I later went to the Netherlands, where I attained my Master of Music. And today, I live in the UK, working as a professional cellist in the London Philharmonic Orchestra, touring the world. But this, however, is quite unusual for me, to stand on a stage just talking to you without my instrument. I can't help the feeling that I have forgotten it somewhere. Okay, so one may now think, okay, she plays in this great orchestra. She's obviously done pretty well for herself. What's the problem? Well, I have a very literal mind. And it constantly clashes with both non-verbal and verbal subtleties in social situations. It gives me a very direct line of approach and speech in everyday conversations. I still don't really understand the purpose of small talk, although I can appreciate it now. And jokes and sarcasm fly completely over my head. My mind just takes things in so literally. It loves to analyze everything. My world is a very intense one. My senses are heightened. My brain absorbs everything in through an amplifier. My special interests can completely consume me. And my emotions, they go from the highest of high to the lowest of low, and they're on and off like a light switch. My family, bless them, they can still stand in utter disbelief when I go from a complete nuclear blast to rainbows and butterflies in less than 2 seconds, literally. So, okay, autism influences my thoughts, my imagination, my senses, my emotions, and the way I process information. But without knowing this, it was very difficult to maintain friendships because our social expectations were so different. I could come across as odd, and I experienced a good amount of bullying for it. But the most devastating were the eroding misunderstandings that dominated the relationships with the people closest to me. Body signals, misread. Words, completely misinterpreted. It was so frustrating. It was like fighting a ghost, something that no one could really grasp, not even the counselors we sought for help. So it was a mentally agonizing situation that persisted year after year. And in my mid-20s, I had reached a really dark place. And I started to be truly scared for my future. But then, something extraordinary happened that changed everything. In 2006, I heard about Asperger's syndrome. It is already an outdated term today, but it is still a form of autism on the high-functioning end of the spectrum. 3 years later, when I was 28 years old, I received this diagnosis. And I realized that a good third of my life had been based upon a false perception of myself. Imagine that. No wonder my life had been so confusing. But now I started to see myself in a new, clear context. My whole life and all my experiences just started to make sense. This launched me on an incredible journey of enlightenment and transformation.
So this is an example of one of those good things that can come from the DSM-5 and having a label for the symptoms a person's experiencing. So figuring that out kind of made the world make sense to this person, right? And launch them on a journey of self-discovery, they're saying. So we'll only watch a little bit more of this, but I hope you've seen a lot of some of the points that we've said about the experiences that people are having. Hopefully that's a lot of what you're getting out of this, as well as a lot more detail on what an autism spectrum disorder is like and how it can influence many aspects of a person's life.
Finally been given something that allowed me to explore the relativity of my perception of the world compared to others. I gained access into that mysterious rule book, and I could start comparing it with mine. And so I learned to identify my differences. So in the coming years, I found efficient ways to improve my social skills. I learned to verbalize my needs, recognize my limitations, and develop my strengths. I found successful strategies to navigate my everyday life and significantly improved all the disabling traits of my diagnosis. But this took a lot of commitment, dedication, and hard work. Because autism is a spectrum, I had to become like a researcher and collect a lot of information from a lot of different sources over a long period of time in order to be able to complete my unique life puzzle. When I thought that I had reached the level of conformity that society demanded, I kept feeling that something was not quite right. Something was still missing. I could change the way I acted, but I cannot change the way I am. My natural biological calibration is and always will be autistic. And the problem I had now was to live up to these new high social standards that I had set for myself. I had come to understand my differences. But as you all know, a relationship is a two-way street. Without acceptance and understanding for the real me, I would never be truly happy. And this prompted me to one day make quite a radical move. On the 2nd of April, 2015, I announced my autism on social media, and I started to talk about it with everybody, openly, bang, just like that. I admit it was absolutely terrifying, because I had encountered what was out there, the stigma, the prejudice. I was very afraid that people would put their preconceived ideas of autism onto me rather than letting me show them what autism can look like. But this didn't happen. What happened was that my life changed completely, almost overnight. I was met with curiosity, and support started to flood in from everywhere, from friends, from family, from colleagues, and from people I didn't even know. Media started to take notice, and people who recognized themselves in my story started to contact me from near and far for help.
So the rest of it is also really good, similar to the last one, of the things that she does to support other people as well, and the continued journey. But with the time that we have in chapters 12 and 13, I think I'll stop there because I think we get a good sense, because that later experience of like showing everybody and joining organizations or founding organizations to help other people, that's not as common as some of these other symptoms of these disorders, and hopefully you've got a better sense now with her talking about these disorders as being neurodivergent, that her brain is working differently, processing things differently. Same with someone with ADHD, their brain is working differently, focusing on different things. That gives them capacities to do things that are just slightly different. And that, one, we should try to understand people's experiences from their own mouths, for one, and then two, understand that they're people. The people who are suffering symptoms of schizophrenia, the people who are neurodivergent, they're people. We can support them. They have specific needs. Yeah. All right. So let's jump to anxiety-related disorders. So essentially, these are, again, we're going back to that definition of abnormal, like at what point is that abnormal? Outside the statistical norm, maladaptive, distressing to the individual. So these are fears or anxieties that are disproportionate and disruptive. So are they maladaptive? Are they disruptive to the individual? Some of these are generalized anxiety disorder, panic disorders, specific phobias, so like fear of spiders or snakes, social anxiety disorders. Anxiety related, but not in the DSM-5 for anxiety disorder, is obsessive compulsive disorder. It's also related to a lot of aspects of anxiety, but it's not actually in the DSM-5 under anxiety. So how to diagnose this? So these are a couple of things that you would see in the DSM-5 is persistent anxiety for at least 6 months. That's essentially a line that a medical practitioner, a psychologist, or psychiatrist would check that box, say, okay, yep, that is one of the symptoms this person is having. Inability to specify reasons for the anxiety. So what is the etiology? What is the cause or the reason for the condition? A lot of it seems to be biological factors. So with that being said, a lot of research has been done into biological factors for a lot of different disorders. And the DSM-5 does emphasize those as well. So not to say there is not biological factors for any of these, but sometimes I do wonder if a lot of research has focused on those biological and ignored some of the other factors, psychological or sociocultural, to the detriment of focusing so much on the biological. But we do have a lot of understanding of the biological, so that's good. So there might be genetic predispositions. GABA seems to be deficient in people who are suffering from anxiety disorders. And I think I accidentally deleted something here. Respiration, am I talking about breathing there? Because I think I'm missing something there, so sorry about that. Psychological and sociocultural factors. So here are some. Harsh self-standards, critical parents, negative thoughts, trauma. So these are all things that might cause and also can be caused by anxiety disorders. So panic disorder is a recurrent sudden onset of intense terror that often occurs without warning. So it's not the same, but if you remember us talking about night terrors, they could just suddenly happen, essentially. Panic disorders are kind of like that, except in day-to-day waking life. So what is the reason for this? Well, there might be some genetic predispositions here. Norepinephrine, GABA, and serotonin seem to play a part. So having those in lower or higher combinations in different ways might lead to this. That might be genetic, like the reason that you have less or more GABA could be genetic. Lactate as well seems to play a part in this. Conditioning to CO2 seems to play a part as well in panic disorder, as well as there are gender differences. So males versus females seem to have different symptoms, different biological factors at slightly greater rates. So if you looked at like the average of GABA, for example, there might be slight differences between men and women. So specific phobias, again, are those fears of specific things. And so it's an irrational, overwhelming, persistent fear of a particular object or situation. So we talked about how easy it is to create a fear of snakes or spiders. So being a little worried about a spider that's nearby you, that's pretty normal or natural. It could injure you. A poisonous snake could injure you. So that's not what we're talking about. An irrational or overwhelming and persistent fear. So not going into long grass because there might possibly be a snake in there. We did see in the week on behaviorism the example of the exposure therapy to decrease fear of that snake. That's a good example of the overwhelming and persistent fear of that snake. So with that, there seems to be a lot of psychological factors. So you might have learned a fear of that creature or that object. Sometimes you might learn that vicariously. So there's accounts of people essentially gaining a phobia of many things because they saw that their parent was really afraid of that thing. There also might be genetic predispositions to this. And as we talked about, it seems like it might be we might have an evolved capacity to develop fears of certain things, like snakes or spiders. So turning that knob like up to 10 or 11 might make that a little more easy to develop a specific phobia. So there are a lot of different phobias. I just thought it would be interesting to put a bunch here. So they've got funny names. I mean, I guess if you speak Latin, they probably don't sound very funny. They probably sound perfectly normal. So I like, there's a lot with A's. Oh, I didn't put one that I don't actually think I've got a phobia of this, but I do get really uncomfortable with like wide open water spaces. Thalassophobia is that one. So like the ocean. Just having the spider on the screen makes you itch. Sorry about that. We'll go to the next slide. I just think it's interesting to see so many different fears listed. And those are specific phobias that any given person could have. And so ways that you might treat that would be something like exposure therapy. So social anxiety disorder is an intense fear of being humiliated or embarrassed in social situations. So you're just anxious about social situations. So there do seem to be biological factors like a genetic predisposition. And so how these genetic predispositions are seen is by looking at say like twins, adoption studies, looking at the genome, seeing with people who have been diagnosed with social anxiety disorders, do they tend to have certain genetic markers? And so finding that correlation suggests maybe there's a genetic predisposition for them. Are those genes the cause of these, or is it that plus environment and things? It's probably a big combination, and it depends probably on the individual. I would assume there's probably some individuals that it could all come from genetics, and then some it's partially genetic, partially environmental, things like that. Neural circuitry as well, and serotonin levels specifically. Psychological factors are overprotective or rejective parenting. So a parent that is really overprotective, shielding from social situations and humiliation and embarrassment, or a parent who's really rejecting, so they are kind of humiliating and embarrassing their child. So, and other social experiences. So you could learn this because you could develop a social anxiety disorder from having maybe humiliation or embarrassing social situations. And have that act kind of as a punishment in a behaviorist way. So that's kind of a punishment. You learn to fear those things. It gets to a point where it's now maladaptive and distressing to you. So it's now reached that level of a anxiety disorder. So obsessive compulsive disorder is persistent anxiety-provoking thoughts or urges to perform repetitive, sometimes ritualistic behaviors to prevent or produce a situation. So you might have such anxiety about germs that you're washing your hands a ton. You might want to produce a positive action, and so you repeatedly, text someone. I'm just trying to make up examples here. You want to produce a healthier body, so you do a ritualistic behavior of like a certain workout regimen and eating regimen, like really specifically, or something like that, or you eat carrots a very specific way. So not that any of these are things that I've actually heard of or worked with, just as examples of some ways it could display. I think the common one that's shown in media for OCD are things like having to adjust and make sure everything's like in the exact right place, matching level, things like that, and washing hands. I feel like those are the two most common in media, but it could also be something like, oh, you cannot step on a crack. So it is anxiety provoking to think of stepping on a crack for whatever reason. So you absolutely you do some kind of ritualistic behavior to avoid the crack. And maybe if you do step on the crack, you have a ritualistic behavior to prevent the situation that stepping on the crack would cause. So biological factors, hey, you have genetic predisposition possibly. So hopefully you're seeing a pattern there. It does seem like a lot of these might be correlated with certain genes, but again, are those the only cause or the main cause? Is it one piece of the whole puzzle for what leads to obsessive compulsive disorder? So overactive brain components in the frontal cortex and basal ganglia have been seen in people with obsessive compulsive disorder. For neurotransmitters, low serotonin as well as dopamine and glutamate are related to them. So you can see when we talked about neurotransmitters, there's not a lot of them. So serotonin, dopamine, they're really heavily involved in a lot of processes neurologically. That's why, as an example, medicines that are working on dopamine for depression can also be used to treat the dopamine imbalance in someone with ADHD. So these neurotransmitters do a lot of different things. Psychological factors, life stress can lead to and cause and then be caused by obsessive compulsive disorders. That's kind of a downward spiral there. You have enough life stressors that now it is turned into an obsessive compulsive disorder around some behavior, let's say the stepping on cracks behavior, and now you have to walk to work every day on a sidewalk, and so you tend to be stepping on cracks a lot, and so you're having more life stress, and then you get to work and you're just extra stressed. Yeah, not great. So with that, there's also difficulty in filtering out those negative thoughts, especially these compulsive thoughts. That's why it's called a compulsive thought, because it just comes, it's a compulsion to have that kind of thought or that behavior. So subtypes of these, there's hoarding, skin picking, hair pulling, body dysmorphic disorder is also obsessive compulsive as well. So post-traumatic stress disorder, I feel like there's been a lot more research on this more recently, which is really good. So your book is a little bit out of date. So if it's something of interest to you, maybe a good topic for a question paper. So usually these symptoms are developing as a result of some exposure to some traumatic event. More recent research suggests that it can also be like experiencing a traumatic event vicariously as well. So like hearing about a trauma from someone who's experienced that trauma can also lead to PTSD symptoms. So some things that might happen, flashbacks, avoidance of emotional experiences, so trying to be emotionally numb, because lots of emotions can be tied to any kind of traumatic event. So there can be emotions of happiness and excitement, as well as fear and terror tied to a traumatic event. And so feeling any of those could trigger some of that neural circuitry for the memories of these kinds of traumatic events. Natural disasters can often cause post-traumatic stress disorders too. So I mentioned this, just not in these words. So an excessive arousal to those kinds of stimuli, triggers essentially is another way to say that. So difficulties with memory and concentration. So that can be just generally across the board. So someone with PTSD might have a hard time memorizing the terminology from the textbook, for example. Impulsive outbursts are common as well. And so that's our anxiety disorders. We're going to jump to dissociative disorders. So, any questions about those? I know we're going pretty briefly over each one of them. There's researchers and bodies of research who spend literally their entire lives like focusing on post-traumatic stress disorders and even specific aspects of it. So there's a lot more than we're covering in this class on each of these. But I'm hoping the additional emphasis on those first couple. How does one overcome the difficulties with memory and concentration? Just therapy? So it depends. Therapy can definitely help to, say, focus and change your concentration, but especially if it's also tied to something like dopamine, having medicine as well can be really helpful. So if with the testing that a psychiatrist and a psychologist would do, they would be able to have a better sense of, is any kind of anxiety disorder exclusively caused by like the neurotransmitters, or is it going to be best to work just on therapy and the trauma? So the difficulties with memory, you can definitely learn through therapy a lot of different memory techniques. We talked about a couple recently in our chapter on memory. So take that and add a lot more. There's a lot more that someone who's trained to work with post-traumatic stress would know to work with. So concentration, memory, you can definitely do therapy. Medicine can also help so that it can alleviate some of the triggers or some of the flashbacks to allow you to then use those skills and techniques from the therapy. So for most of these disorders, the treatments, not all of them, but for most of them, a combination of drugs as well as therapy tend to be the most helpful overall. But then it is also individually dependent on the person. So. But yeah, you can definitely learn a lot of skills, form better memory and concentration through therapy. And we'll talk about other specific treatments for PTSD in chapter 13. But for the memory and concentration specifically, a lot of therapy. But the medicine can kind of help, I guess you could say, take the edge off the symptoms to allow that therapy to work and learning those skills. Yep, there's a lot of different things that even now are considered hard drugs and hallucinogens and other things that are being tested for treatment with people with PTSD and many other disorders too. So hopefully, especially with changes in laws in various states, it'll be a little easier to do that research for the researchers so that we can have a better sense of what kinds of chemicals can help and what kind of treatments are going to be the most effective. So, but definitely talking with doctors, psychologists, psychiatrists about what you've heard about, see if they think it's a good idea, is what is probably the best way to go about that. But yeah, absolutely. So dissociative disorders are in different ways a loss of memory or changing of identity. So essentially you're disassociating with your current identity. So you have a current identity or even ways that you see yourself in different contexts. So an identity for, say, school versus work versus home. So this is completely disassociating from that identity in some way. So disassociation is one way that we might deal with extreme stress. So it seems to be adaptive, like it helps to kind of step completely away from that stress by totally disassociating with it. So with that, it also is problems integrating with emotional memories. So you might disassociate with, say, a traumatic memory. So you see yourself as a totally different person in the trauma. That's another example of dissociation. This dissociative disorders, we'll talk about a couple. So amnesia and dissociative identity disorder. So you've probably heard of amnesia. You might not have heard of dissociative identity disorder by those terms. So dissociative amnesia is when someone experiences an extreme memory loss regarding their identity caused by some kind of extreme psychological stress. So they no longer see themselves as that same person. Maybe they don't even remember the person they actually are, even down to their name. That would be dissociative amnesia. They essentially forget who they are. Now they're a new person. I can only think of like media examples, not like real actual symptoms of real people. And the media examples aren't great because generally the author of those books or movies knew a little bit about it, but it's not a perfect fit for it. So I won't actually cite any media examples. We'll say it does kind of make me want to watch The Bourne Identity again, though. As an example of one of the ideas that came to my head, but not a perfect example. No, good question. For dissociative amnesia, it can happen at any time, essentially. And it can be from any kind of extensive psychological stress, so it doesn't have to be a trauma. It could be a trauma, but it could also be, let's say, for example, you are suffering from obsessive compulsive disorder, and it is so distressing to you, you then disassociate. So it can happen like immediately within the trauma and then you dissociate, or maybe years later you suddenly dissociate and it was caused by that kind of extreme stress. So usually you can pinpoint like the cause was the extreme stress from XYZ, whether it be a trauma or extensive stress over a long period of time. You just lost your job and you're very stressed, in debt, you now have developed dissociative amnesia. So but it doesn't have to happen immediately. So not only when the trauma first happens, it can happen later on too. But usually there is some like a stress or a stress trigger, even if the trigger is kind of like extended or it doesn't seem like it's immediate, like the trauma happened like 2 years ago. Yeah. So dissociative identity disorder, you might have heard of from the name multiple personality disorder. So I think there's another comment. My phone's buzzing earlier when I'm getting comments before it's actually coming across on Teams. So sorry about that if I'm responding to your comments a little bit after you've said them. My phone seems to be getting the comments first. Oh, never mind. It was the same buzz, but that one was a text from my brother. So leave me alone. I'm working. So dissociative identity disorder is, you've probably heard of it referred to as multiple personality disorder. So with this, it's now called dissociative identity, essentially because you're dissociating your identity into more than one identity. Usually like the dissociative amnesia, you've kind of forgot who you are, or large aspects of life are now forgotten. You've dissociated from that and you're one person. Dissociative identity is kind of similar, but you have more than one personality, more than one identity inhabiting the same space of your physical body. So with that, each personality can have unique memories, behaviors, and relationships with people in your life. They might have memories that another identity is not privy to, that they're not connected to, because that event happened to identity C, but not identity F, for example. It tends to be only one personality is dominant at any given time, but through therapy, generally you're trying to integrate personalities or these identities to one individual identity. So through therapy, you're kind of trying to bring them together under one dominant identity in the end. So with this, what's it caused from? It seems in many cases extraordinarily severe abuse in early childhood. So it does also appear to run in families. So it's more common in children who have parents who had it as well. So is it genetic or not? The genetic evidence specifically is a little less clear than the fact that it does appear more common in families. Social contagion or social construction. So can it be evoked by a therapist? There's some that suggest that maybe therapists who, for example, we saw the, oh goodness, what was her name? Eleanor at the beginning, the very first video we watched. The therapists she was first going into were really interested, and you might even say excited, about hearing these symptoms of schizophrenia. It's an unusual disorder, probably rare that they come across someone who's suffering from symptoms of schizophrenia. They might find it cool, like as an interesting thing to them scientifically. So in some cases, it seems like perhaps therapists have kind of created an identity and a dissociative identity in clients. Maybe, was it already there, or did the therapist kind of lead for that to happen? Maybe, maybe not. Yeah, let's watch this first one because it's specifically about DID. Again, it's more useful to see, I think, rather than me explaining it. I think this one has some examples from a couple actual people, or did that one get removed from YouTube and I had to find this one? I think this one has some examples. I hope it does.
In 1955, a woman named Shirley Mason visited the psychotherapist she'd been seeing for a few months. When the therapist asked her how she was doing, she said, "I'm fine, but Shirley isn't. She was so sick she couldn't come, so I came instead. I'm Peggy." Through continued therapy, the therapist discovered what seemed like 16 personalities living inside Shirley's mind. She later wrote a now famous book about Shirley titled Sybil, using a different name to protect her patient's privacy. And that book put a rare syndrome, then called multiple personality disorder, on the map. Before Sybil, fewer than 100 cases had ever been reported, but after the book came out, diagnoses exploded into the thousands. In a surprising twist, Shirley's specific case might not have been real, and she eventually wrote her therapist claiming she'd made it all up. But researchers are still looking into the disorder as a whole. Today, we call Shirley's diagnosis dissociative identity disorder, or DID. It often occurs alongside other psychiatric disorders, making diagnosis very difficult, and it's still very controversial among psychologists and psychiatrists. But what's not controversial is that the way Hollywood portrays it is way off. To be diagnosed with DID, a patient needs to have 2 or more so-called identities, or personality states. This doesn't necessarily mean a whole other person is living inside their mind. In many cases, it's more like their overall personality is fragmented and different parts of their history and self-image can take control. For example, only one personality state might be able to speak a language learned during a semester abroad in college, while another doesn't remember that experience. Or if they've previously been a very religious person, they might have one fragment of them that's devout and another that isn't. Sometimes these fragments present themselves as multiple people with different ages or genders, but not always. And while these fragments can be complicated with their own wants and aspirations, they aren't there to fulfill like evil or criminal desires. So the idea that people with DID are ruled by the worst parts of themselves, like in Fight Club or Split, is entirely fictional. The other major symptom is memory loss or amnesia. This could be missing personal information about themselves or missing memories from times when another personality fragment was in control. Also, it doesn't count if the personality shift or memory loss are chemically induced. If everyone tells you that you turn into someone else when you're drunk, you can't remember what you said or did, you do not have dissociative identity disorder. And parents, imaginary friends, totally cool. They're really common, like 2/3 of kids have them, and this is not a symptom of your child harboring another secret personality. But if a patient has multiple identities, their memory is shaky, and they're distressed or impaired by these symptoms, then a psychiatrist might diagnose them with DID. Many, though, wouldn't. It's not that their condition isn't real. There's no denying that patients have these symptoms, but experts disagree on where the symptoms come from, whether DID is a standalone disorder or whether it's better explained by other well-established disorders. Surveys of psychiatrists found that most agree it's a valid diagnosis, but many think it's commonly misdiagnosed. That's partly because DID is so rare. Most studies on it have very small samples, but it's also because it's very unlikely that patients get just a DID diagnosis. It's usually tacked on to other diagnoses, and this is one reason why many psychologists think that it's better understood as an extreme version of other disorders. For example, DID can look a lot like a dissociative fugue state. This is a kind of temporary memory loss where people behave impulsively, leave their homes, and wander around, and do things that they would never otherwise do. So it might seem like a shift in personality. These people often lose their memories of who they are, so they sometimes invent a new identity to fill in the gap. And although a lot of these fugue cases are a bit of a mystery, some are explained by substance use or neurological conditions. CID also overlaps a lot with post-traumatic stress disorder, or PTSD. That's especially interesting because the psychologists who most strongly believe DID is a distinct disorder think it stems from childhood trauma or abuse, which could also cause PTSD. And DID similarly shares symptoms with borderline personality disorder, which is characterized by impulsive behavior as well as unstable relationships and identity. One study of 33 patients in the 1980s found that 70% of patients with DID could have just as easily been diagnosed with borderline personality disorder instead. But
So that's one other good example of why having like the DSM-5 is really useful to try and avoid that kind of problem. Obviously, the diagnoses are still not perfect, especially when scientists are still trying to say, well, hey, is this just a more extreme version of other trauma responses, or is this kind of amnesia symptom and disassociating and having these multiple identities, is that a symptom caused by many disorders? And maybe that's the case. So hopefully further research makes it a little more clear.
the researchers concluded that because 30% of the cases were distinct, DID should be considered a standalone disorder. DID is also controversial because many of the new diagnoses seem to be coming from just a few psychiatrists, and some suggest these doctors may be overzealous because they're eager to find new cases. But the doctors themselves counter that by saying that they're just better at seeing the signs and identifying the disorder. Regardless, the good news is that treatment for DID with tailored therapy, at least for the symptoms related to identity fragmentation, is pretty effective, which is great because although there's a lot of controversy surrounding the disorder, psychiatrists all agree that real people are suffering and need help. And like anyone else, they should be shown compassion and not made into movie monsters. Thanks for watching this episode of SciShow Psych. If you want to learn more about the psychology of trauma, you might be interested in our episode on how...
So I'm sorry that one didn't actually have examples of someone suffering. There was one video that I had earlier on that must have got removed from YouTube. Sometimes this happens with like older documentaries and things. They just get pulled or made private. So that's probably what happened. But it was a good explanation, kind of dove into a little more depth of how it's connected to other disorders. So I thought that was really useful, which is why I changed to this video. But it is interesting to see how people do live with this disorder, as well as we've seen some schizophrenia, autism spectrum disorders as well, and their own experience. So I do like to bring that into it. So 9:22. It's this class goes till 9. My other class goes till 4:22, right? We've got still like another 30 minutes, right? I'm not going over time. Is that correct? My memory is deciding not to pull up the information very well. Let's pull up the syllabus. It's all in the syllabus. Okay, yep, 9:50. That's what the syllabus says? Perfect. Sorry about that. Suddenly my memory was like, class is supposed to be over. But I didn't feel like it was, because I'm like, no, we should be able to get through a little more before the end of class today. All right, so let's jump to major depressive disorder. So here, with that diagnosis and symptoms, here are some of the things that you would find in the DSM-5 to then diagnose with major depressive disorder. That is significant depressive episode that lasts for at least 2 weeks. Daily functioning being impaired. So there we see again this behavior that has to meet that standard of, is it impairing, is it maladaptive to your day-to-day life? Also, is it distressing? So you need to have those things. So oftentimes people have a feeling of being depressed because of a specific event, right? So it wouldn't be major depressive disorder without meeting these criteria. So symptoms for depression are pretty wide and varied, making it kind of hard to, well, maybe not hard, making it so lots of different symptoms fall under depression. So fatigue, sense of worthlessness, reduced interest, difficulty concentrating, lack of motivation, appetite changes, and sleep disturbances. So among other things. So these are some of the things that would be listed in the DSM-5 for major depressive disorder. So what are some causes of this? Well, probably some biological factors, like again, genetic predisposition might be at play here. An underactive prefrontal cortex, so that upper prefrontal area of your brain, and the regulation of neurotransmitters, serotonin, dopamine, play a role in mood, as well as regulation of a lot of processes in the body. So those psychological factors, learned helplessness can lead to depression. So we talked about that in behaviorism. So that's an example of when, say, a dog is in a Skinner box and it jumps to one side and it's getting shocked, it'll jump to the other side where it's not getting shocked. If you start to shock the entire floor and it can't get away from the stresses and uncomfortable shocking, it learns to be helpless, can also lead to depression. Makes sense, right? If you cannot change the situation, that can be very distressing, can last over 6 months, lead to a lot of these symptoms. Rumination on negative or self-defeating thoughts is another psychological factor, a cause and consequence as well of depression. Pessimistic attribution as well, so looking at things through that pessimistic lens. So these can, one, contribute to developing depression, as well as they can all also kind of be a symptom of depression. So you can kind of see that downward spiral there, and this focus on a lot of negative from like DSM-5. Sociocultural factors, poverty, makes sense. It's a stressful situation to be in poverty, right? So if that is there, maybe learning helplessness, and also have that genetic predisposition, that's 3 poor strikes in that. If we think of the developmental cascade, that's a couple risk factors added together leading to a possibility of negative outcomes. But if you have maybe some supports that reduce some of these problems, then some supports, then maybe the sociocultural factor of poverty is not in play there. Gender differences, women are 2 times more likely to be diagnosed with major depressive disorder than men are. So another mood disorder is bipolar disorder, and this is an interesting one. That is, well, let's talk about the couple different kinds. And in one kind can look almost essentially exactly like major depressive disorder with just one specific difference. So bipolar disorder is characterized by extreme mood swings that include mania. With that being said, a lot of lay people talk about, oh, my friend's totally bipolar today or something like that because they were acting one way in the morning and one totally different way in the afternoon. That's not actually a symptom of, well, I mean, it could be related to symptoms. That wouldn't be part of the diagnostic criteria for bipolar. The frequency and separation of episodes is actually quite a lot longer than generally people think. So usually that period of mania versus that period of depression is separated by like 6 months to a year. So you have like 6 months where it just looks like depression. Then all of a sudden you have 3 months of mania, and then or 6 months or a year of mania, and then back to another 6 months or a year of depression. So for that first 6 months, a year, it might just look exactly like depression. So there is, do I have it in here? Nope, I don't have it in here. There is a rapid cycling for bipolar disorder. Rapid cycling is only 3 months. So that's as rapid as bipolar gets, is like change within 3 months. So having a 3-month period of mania, 3-month period of depression, 3-month period of mania. Usually for bipolar, this isn't true for every single person diagnosed with bipolar, but it tends to be most of the time they're in the depression rather than the mania. So if they are in, say, a period of depression for a year, they might be in the period of mania for the 6 months or even the 3 months for rapid cycling, and then back to that period of depression. So with this, it seems like there is a strong genetic component and there is some metabolic activity that seems to be highly correlated with the swings and those timings of the swings and the activity in the cerebral cortex, as well as various neurotransmitters like serotonin and dopamine. They do a lot of different things. So there needs to be a lot more research, and there is a lot more research being done on how they are affecting the brain, mood, the swings between mania and depression for bipolar disorder. So that's one thing I do hope you take, like, years from now, when you think back to your psych class, if one of the, 10 things that you remember is bipolar disorder isn't like changing day by day. It's pretty big spans of time. Like the mania period's going to last a couple months, or the depression period's going to last a couple months. It's not a super quick change. Like is often referred to, just in like lay speaking about it. All right, moving on to different kind of disorders. Eating disorders. They are more common in girls than boys. Anorexia nervosa is pursuing thinness, and generally through starvation. So you might restrict energy intake. You might also be vomiting as well. There is usually an intense fear of gaining weight. And a disturbance or a distorted view of self in how your weight or your shape is experienced. So that's kind of indicated by this mirror here. This person is seeing themselves looking very different than they actually do look. So that distorted view of self. Typically starts in mid-adolescence, and it usually follows a period of dieting as well as stress. So this might be a first or even second diet that a person is on, like a normal healthy diet, but then in addition to stress, maybe even a stress as simple as midterms in middle school or something like that. Plus they've been dieting, that is very highly correlated with the beginning of anorexia. So with that, teens generally do set high standards for themselves, and they oftentimes can't meet those standards. And so they do tend to turn to something they can't control, like their weight. So that's something that is controllable. They focus on that, especially if stress of a midterm and then they failed the midterm, that kind of thing. Those combinations of risk factors together, one of those possible outcomes could be anorexia nervosa. Family stresses also linked with it. Makes sense. Stresses in general. Genes seem to play a role. The physical effects of dieting might actually change the neurology of your brain to make this distorted pattern the norm as well. And so with that being said, the pattern of dieting and having that stress might actually be setting up a neurological circuit that you're kind of getting reinforced or rewarded for controlling your intake and your eating and your weight. So even though you're out of control of, say, your grade in history class, you've kind of started to create this neurological circuit, essentially, is what that's saying. So in different terms. And then as it becomes more of a habit, it becomes more of a habit. It becomes an easier thing to do. It just is the base pattern. So bulimia is slightly different. It's a binge and purge pattern through vomiting or laxatives. It So generally, eating a lot quickly happens here, and there's a lack of control of eating during the episode. It tends to be seen as slightly not as bad. I was about to say slightly more healthy, but neither of these are healthy, obviously. So slightly less bad than anorexia because you're getting some nutrients before purging. So getting some nutrients is better than no nutrients. And so with that, this would be at least 2 times a week for 3 months. So over that course of 3 months, are you doing that more than 2 times per week? Yeah. So preoccupation with food and a fear of becoming overweight tends to be common for bulimia, depressed and or anxious. So with this, a lot of these disorders, especially if it's distressing to you, might be comorbid, so happening at the same time as anxiety disorders. So if the symptoms of your schizophrenia, the symptoms of the Asperger's, the symptoms of the ADHD, the symptoms of bulimia, if they're distressing to you, you might also be having developing an anxiety disorder at the same time. That's why it's a very common one to be comorbid with a lot of different things. Distorted body image here for bulimia as well. With that, people with bulimia often do fall within the normal weight range, so it can be hard for like people outside to detect. So a parent, a friend, a roommate, a partner, it can be hard to detect if you're not actually seeing them do the behaviors of eating and purging, so binge eating and purging. So oftentimes, people who develop bulimia are somewhat overweight before the disorder, and it also tends to start after a period of dieting as well. So cognitive behavioral therapy is some of the most effective for these eating disorders, so whether it be bulimia or anorexia. So there's also binge eating disorder, which is basically just recurrent episodes of out of control eating, not necessarily purging at all or being as concerned with like body image, just the pattern of overeating a lot. So with this, eating disorders do seem to have a strong genetic component and problems with some neurotransmitter regulations. So yeah, like many of these things. Let's talk about schizophrenia. We had the example from the video, so hopefully you can remember that now that it's been a couple hours since we watched that video. The primary symptom of schizophrenia is actually highly disordered thought. So we tend to think of schizophrenia as, oh, they're having hallucinations. And we learned earlier today that auditory hallucinations are the most common. But really, the highly disordered thought is the biggest and in some ways can be the most maladaptive symptom as well. So this can go all the way from like a split from reality, so not even understanding your current person who's having this, that not even understanding their current reality and seeing the world for reality, or it can be less than that, like disordered thought. The idea, thinking the symptom that the therapist thought Eleanor had of a distorted thought that she was a news reporter. She wasn't reading the news for TV. She was doing it for a student group. So, but that it can be a pretty dramatic range there in that split from reality. With that, it is typically diagnosed in early adulthood. That's generally where the symptoms are the most clear. It doesn't seem like symptoms of schizophrenia, as schizophrenia itself, really start any earlier than about age 14, but it's usually diagnosed in early adulthood. So the symptoms of schizophrenia are broken up into positive versus negative symptoms. These are more positive and negative, like behaviorist positive or negative, additive things or things taken away from the person. So positive delusions, thinking that you're a news reporter, would be an example of a delusion. Hallucination, those auditory voices, that's being added to your sensation and perception. Disorganized speech, so trying to speak, but it's just not coming out right. So the example of Eleanor didn't really talk about her experiencing that, So I'm not actually sure how a person themselves would be experiencing it, if they're not thinking up the right words or if it's just not coming out the same way. For negative symptoms, so these are kind of like things taken away or out of the situation of the person, a flattened affect, so kind of neutral, flattened affect, not having really extreme highs or lows, reduced speech, so just not speaking, which you could see how maybe these two, disorganized speech and reduced speech, might be connected. So if you're not able to express yourself, you might not be speaking. A lack of initiative as well, not wanting or feeling motivated to do things. So, here we go, our page on positive symptoms and negative symptoms. So some cognitive symptoms are also attention difficulties and memory problems. So this can add to or even cause things like delusions. So if you have memory problems, you might be remembering things together that weren't actually together to make you think that you're a news reporter, or have a delusion that is maybe not that extreme or clear, a disordered thought pattern as well. But that first thing is that disordered thought. So that disordered thought can lead to things like that disorganized speech, like this attention difficulties, like the memory problems, and this one especially, the impaired ability to interpret information and make decisions. It's just not getting processed exactly right. So it's disorganized. And that is one of the things that makes it harder for people suffering from these symptoms of schizophrenia to interact with other people. Because of that disorganization, the world kind of doesn't make sense. And some of these delusions or the hallucinations, if they have them, positive symptoms are actually more rare than negative symptoms. The negative symptoms are more common than positive symptoms, but that can make it harder to make sense of the world around you. So there might be a genetic predisposition to schizophrenia. There might also be some structural brain abnormalities. So whether that comes from like injury, like a concussion earlier on in life, things like that, and also regulation of various neurotransmitters. Psychological factors, the vulnerability stress hypothesis is essentially saying, hey, if you have these genetic predispositions as well as stress, that might make it so it's a lot more likely that you'll then suffer from schizophrenia. So sociocultural factors might influence how this disorder progresses. So in the case of Eleanor, the sociocultural factors of talking to your friend and having that stigma led to some negative interactions with the symptoms. Then having therapists who weren't as great led to how the disorder progressed negatively. And later on, better therapists led to more positive disorder progress. So this is another video on schizophrenia that we won't watch because I think that first one gave a lot of good detail. It didn't talk about every single symptom, but I think that's a good one to go from there. So personality disorders is another category of disorders, and I'm not sure if we'll get through it. Oh, yep, I guess we only have a little bit on personality disorders in this class. Your book talks about these in a little more detail than we will here, but I want to name a couple. So these are, so hopefully you remember back to the chapter on personality. I actually taught the other class the chapter on personality just earlier today, so it's really fresh in my mind. So personality is supposed to be something that's really stable across time. We talked about traits, we talked about humanistic personality, we talked about biological theories related to personality, how our biology might actually be the cause of what we call these specific traits. So think like extroversion, introversion, neuroticism, definitely neuroticism for disorders, openness, conscientiousness, those kinds of things. The way people behave and tend to behave in various situations, that's kind of stable. So have that in your mind when we're talking about a personality disorder. It's different than that. It's maladaptive in some way. The personality is maladaptive. It's distressing to the individual. It might even be potentially harmful to that person's self or others. So antisocial personality disorder is diagnosed by a personality style that seems to be pretty consistently breaking the law, doing violence, deceit without regretting these things, being more impulsive, irritable, reckless, and irresponsible. So it would be a personality type that is pretty maladaptive, essentially. You could think of it that way. So with that, it seems like there's a lot of biological factors here. Genetic, brain, autonomic nervous system differences, traumatic brain injuries might lead to it as well. So that's an example of one personality disorder. One that is, I think, what might be sometimes confused as, well, we talked about borderline personality being confused as DID earlier. It is actually a personality disorder where you will see the dramatic shifts of someone with their emotions really completely flipping. But more intense than just your friend that gets kind of happy and sad quickly, or I mean, I guess I shouldn't say that, because a friend, you could have a friend with borderline personality disorder, right? So it's not a good example. Let's just talk about borderline personality disorder. So the diagnosis and symptoms here are instability in interpersonal relationships and self-image. So a lot of impulsivity, a lot of insecurity, a lot of unstable emotional reactions, and very extreme emotional reactions. So when you're thinking personality should be kind of stable across situations. That's the basic idea around the original idea of personality. So a disorder there that's borderline personality, hopefully you can kind of get a sense from that term that their personality itself is kind of on the border and on the line of that border. So they're flipping one way or another. Extreme emotional reactions. You might talk to a friend and they are super happy and excited to see you. You're the best person in the world. It's really extreme. And then you say something they don't like, and now all of a sudden an extreme reaction the opposite way. So now almost immediately you're the worst person, they hate you, you're trying to destroy their life kind of thing. That kind of extreme back and forth could be indicative of borderline personality disorder. So it does seem that this has some genetic components. Childhood abuse is common for people who suffer from borderline personality disorder. The irrational belief that you're powerless or unacceptable, or that others are hostile, as well as hypervigilant. So hopefully you can kind of see that powerless and you're unacceptable. That's at the one extreme versus others are hostile. So you're on the defensive, you're hypervigilant against them. That's kind of another extreme. So these kind of really dramatic extremes in personality and responding to people with very quick switching is pretty indicative of borderline personality disorder. And that's one reason why a lot of cases of DID, dissociative identity disorder, a lot of it's parallel to some people's experience of borderline personality disorder. So they literally seem to suddenly have a totally different personality. Not so much of like the I forgot who I was kind of thing, where I have a different name and a totally different identity, but I'm behaving characteristically very different in this situation than this one. Oh, that's it. Thank you, Des, for sharing that video. I'll definitely watch it, and I might even put it into future lectures, because I definitely like having that those videos of those firsthand accounts. So I'll see what that is afterwards. But thank you for sharing that with the class. I appreciate that. So I think I'd rather end on this topic than the next topics that we'll touch on next time at the beginning of class. So let's stop there with borderline personality disorder. Thank you very much. Maybe it gives you a couple moments to watch the video that Des shared, or some of the videos that we had to skip if any of these are of interest to you. Additionally, there's a lot that we do not get a chance to cover on many of these disorders. If there's a family friend that you know suffered from borderline personality disorder and you want to learn more about it, It's a good idea for a question paper. So thank you all for being here this evening and participating. And I hope you have a good night. We will continue with chapter 12 next week.